Good evening, all. So, in today's class, we will be discussing the important things related to the pancreas. Okay. So, this diagram shows the location of pancreas. Okay. Shows the location of pancreas. Okay. So, this is the C-shaped. Okay. C-shaped concavity of duodenum. Okay. C-shaped concavity formed by the duodenum. This is the D1. This is the D2 and this is the D3, first, second, and third parts of the duodenum, which is forming a C-shaped curve. Okay. So inside the C-shaped concavity of duodenum, we have the head of pancreas. Head of pancreas. Okay. So this yellow color structure is the pancreas. Fine. Which will be having certain parts like head. The one I am marking now is called as neck. Then we have the body of pancreas. Then we have the tail of pancreas. Okay. So the head of pancreas is located within the C-shaped concavity of the duodenum. Fine. And you will be knowing this is the right side and this is the left side. Okay. So this is the spleen, right? Which is located in the left hypochondrium, isn't it? So the pancreas is directed from right to left. Pancreas is directed, it is located almost horizontally from right to left, head, neck, body, tail. Okay. So you can see in this diagram, the tail of pancreas comes in contact with the hilum of spleen. Okay. So what is the vertebral level of the pancreas? Yes, L1 and L2. The vertebral levels of the pancreas is L1 and L2. Okay. And it is resting over the posterior abdominal wall. Okay. That means the pancreas is a retroperitoneal organ. Okay. Pancreas is a retroperitoneal organ. Okay. Because it is resting directly over the posterior abdominal wall. Okay. So generally we say pancreas is a retroperitoneal organ. Okay. But actually except the tail of pancreas, because the tail of pancreas is intraperitoneal. Okay. Intraperitoneal. Why I am saying tail of pancreas is intraperitoneal? Because it is located within the lienorenal ligament. Yesterday we have studied, right? Gastrosplenic ligament, lienorenal ligament. Okay. So the tail of pancreas is one of the contents of lienorenal ligament, which is a peritoneal fold, right? That's why tail of pancreas is intraperitoneal. Right? So when I say pancreas is retroperitoneal, that means it is fixed. It is a fixed organ. Okay. Fine. Now, coming to the parts of the pancreas. Okay. You know the parts of pancreas, right? So from right to left, the four parts of the pancreas: head, neck, body, and tail, isn't it? Tail is the narrow left end of the pancreas. Right? And other than the four parts of pancreas, we have two projections called as processes. So what are the two processes of the pancreas? Yes, one is called as uncinate process. Uncinate process, which is a projection from the head of pancreas, from the lower part of the head. Okay. From the lower part of head of pancreas, we have a projection called as uncinate process. Okay. Other than uncinate process, we have one more projection called as what? Tuber omental, isn't it? Tuber omental, which is a very small projection. Okay, this one. Tuber omental is a very small projection from the upper part or upper border. Okay, from the upper part or upper border of which part of pancreas? Body of pancreas, exactly. Okay, from the body of pancreas, from the upper border of the body of pancreas, we have the small projection called as tuber omental. So these are the two processes of the pancreas. One is uncinate process, another one is tuber omental. Fine. Now we are going to discuss about the relations, important relations of the various parts of the pancreas. Okay. Actually, for the head of pancreas, we have to remember the 3 or 4 posterior relations, which are clinically important. Okay. So what are the important posterior relations of head of pancreas? Yes, just behind the head of pancreas, we have important structures like IVC will be there, inferior vena cava will be there. Okay, then common bile duct will be there, CBD, common bile duct. Okay, common bile duct. Fine. Then we have the terminal parts of the right and left renal veins, because they are on the way to drain into the IVC, isn't it? This is the IVC. So the terminal parts of the right and left renal veins, okay, right and left renal veins both. Fine. And some other structures will be there just behind the head of pancreas, like right crus of diaphragm, right psoas major muscle, like that. Okay, so just we are talking about the important main posterior relations of head of pancreas. What are they? Yes, inferior vena cava, IVC, then CBD, then terminal parts of the renal veins, both renal veins, right and left renal veins, their terminal parts. Right? Yes. And this diagram is showing the posterior relations of neck of pancreas. This diagram shows the posterior relations of neck of pancreas. What are they? It is marked with the dotted lines. Okay, so this is the neck of pancreas. Right now I am marking the neck of pancreas. Okay, fine. So just behind the neck of pancreas, the superior mesenteric vein, okay, joins with, okay, to form the portal vein. Fine. So that is the importance of the neck of pancreas. Just behind the neck of pancreas, we have the formation, okay, formation of portal vein or commencement of portal vein by the union of superior mesenteric vein and splenic vein. Fine. Okay. And what is the anterior relation for the neck of pancreas? What is the anterior relation for the neck of pancreas? Yes, the neck of pancreas is anteriorly related to the stomach, the pylorus of stomach. Okay. So you can remember as the neck of pancreas is anteriorly as well as posteriorly related to peas, anteriorly related to pylorus of stomach, posteriorly related to portal vein formation. Right? And from this diagram, can you please tell me the anterior and posterior relations of uncinate process of pancreas? I hope you will agree. This is the uncinate process. Okay. This is the head of pancreas. Okay. So from the lower part of the head of pancreas, we have one projection called as uncinate process. This one. Okay. So what is the anterior and posterior relations for the uncinate process? That's my question. This question has been asked in the previous NEET exam. Okay. So take care. Uncinate process. Okay. The anterior relation for the uncinate process is, okay, anterior relation for the uncinate process is, okay, by looking at the diagram, you can easily tell me. Yes, superior mesenteric vessels, exactly. Superior mesenteric vessels, that means artery as well as vein. Okay, superior mesenteric vessels, they are anteriorly related to uncinate process. And what is the posterior relation for the uncinate process? Yes, the uncinate process is posteriorly related to abdominal aorta, isn't it? Take care of the anterior and the posterior. Asked in the previous NEET exam, if there is tumor affecting the uncinate process of pancreas, which of the following structure will get compressed? Okay, so obviously anterior to the uncinate process, we have the superior mesenteric vessels. Posterior to the uncinate process, we have the abdominal aorta. So all these blood vessels may get compressed if there is tumor arising from the uncinate process of pancreas. Fine. Okay. Now, let me ask you one question. Okay. If there is, I hope you will be knowing carcinoma of pancreas. Okay. Carcinoma of pancreas usually arises from which part of the pancreas? Is it from head, neck, or body, or tail? Which part of the pancreas is commonly affected by carcinoma of pancreas? Yes, head of pancreas. Carcinoma of head of pancreas is common, relatively common. Okay, so if there is carcinoma arising from head of pancreas, what are the possible structures that may get compressed? Yes, whatever structures which are located just behind the head of pancreas. Okay, so the possible structures that may get compressed due to the carcinoma of head of pancreas, okay, will be the most important structure is common bile duct. Okay, so what will be the clinical feature of the common bile duct obstruction? Yes, there will be obstruction to the bile flow, isn't it? So finally, it will lead to obstructive jaundice. Okay, obstructive jaundice. Due to increased bilirubin, the patient will be suffering from obstructive jaundice. Okay, fine. So this question has been asked. Okay, carcinoma of head of pancreas will result in compression of which of the following structure? CBD compression, leading to which clinical consequence? Obstructive jaundice. Okay, and what are the other possible structures that may get compressed? Yes, IVC may get compressed. Okay, IVC may get compressed. Then terminal parts of renal veins. Okay, terminal parts of renal veins may get compressed. Okay, and even it may lead to compression of portal vein compression. Actually, portal vein is related posteriorly to the neck of pancreas. But if there is expanding cancer, if the growth, malignant growth is expanding, okay, it may also lead to compression of portal vein. Okay, so what will be the clinical feature of the portal vein compression? Yes, the portal vein compression will lead to what? Exactly, portal hypertension. Due to increased pressure in the portal vein, there will be portal hypertension, and it may lead to ascites. Okay, ascites. Fine. So take care of this slide and also take care of this one. Okay, what is the anterior and the posterior relation for the neck of pancreas? What is the anterior and the posterior relation for the uncinate process of pancreas? Okay. Then coming to the body of pancreas. Okay, body of pancreas. There are numerous relations to the body of pancreas, but let's talk about the important relations. Okay, so yesterday when we talked about the spleen, I have told you the splenic vein will run just behind the body of pancreas. Okay, so the posterior relation for the body of pancreas is splenic vein. Okay, splenic vein. Posterior relation for the body of pancreas is splenic vein. Okay, fine. And the superior relation, okay, superior relation for the body of pancreas is splenic artery. Yesterday I have told you when we talked about the arterial supply of the spleen. Okay, yesterday I have talked about the arterial supply of the spleen. That time we have studied the along the superior border of the body of pancreas, we have the splenic artery running. Okay, so posterior relation splenic vein, superior relation to the body of pancreas is splenic artery. Fine. These two are the important relations to the body of pancreas. Fine. Now, what about the tail of pancreas? So, related to the tail of pancreas, there are 4 or 5 important things. Okay, let's see one by one. As I told already, the tail of pancreas is the only intraperitoneal part of pancreas. The entire pancreas is retroperitoneal except tail. Tail is the only intraperitoneal part of pancreas. Fine. So what is the significance? Since it is intraperitoneal, okay, it is the most mobile part of pancreas. Okay, it is the most mobile part of pancreas. Okay, and what is the reason why I am saying it is intraperitoneal? Yes, because it is located within the, okay, it is located within the one peritoneal fold called as lino-renal ligament. It is a content of lino-renal ligament. Okay, fine. And one more important thing is, you know, the tail of pancreas comes in contact. Comes in contact with which part of the spleen? Exactly, it comes in contact with the hilum of spleen, isn't it? it comes in contact with the hilum of spleen. So what is the significance? Yes, during splenectomy, okay, during surgical removal of the spleen, okay, during splenectomy, the tail of pancreas should be preserved, okay. Tail of pancreas should be taken care, okay. What will happen if there is accidental injury to the tail of pancreas during splenectomy? Exactly. Accidental injury to the tail of pancreas during splenectomy will result in, okay, will result in injury to the islets of Langerhans. Okay, I hope you will be knowing this thing. The maximum numbers of islets of Langerhans are present in the tail of pancreas. Okay, tail of pancreas contains the most abundant, okay, islets of Langerhans. Okay, so injury to the islets of Langerhans will, so that the patient will become diabetic. The patient will become diabetic due to the loss of maximum numbers of islets of Langerhans. Okay, due to insulin deficiency. Fine. So this thing we have to remember. Okay. So remember, tail of pancreas contains the maximum numbers of islets of Langerhans. Fine. Yes. Now let's talk about the ducts of the pancreas. Okay. Let's talk about the ducts of pancreas. So the pancreas contains two ducts in order to drain the secretions, okay, pancreatic juice into the second part of duodenum. Okay, so this is the second part of duodenum. Okay, so right now I am tracing the main pancreatic duct, this one. Okay, right now I am tracing the main pancreatic duct, okay, which is also called as duct of Wirsung. Okay, main pancreatic duct, otherwise called as duct of Wirsung. And right now I am tracing the accessory pancreatic duct, this one. Okay, let me use some other color. I am marking in red color. Okay, this is the accessory pancreatic duct. Okay, accessory pancreatic duct, otherwise called as duct of Santorini. Okay, so what are the two pancreatic ducts? One is called as main pancreatic duct, called as duct of Wirsung. Another one is accessory pancreatic duct, otherwise called as duct of Santorini. Okay, I hope you will be knowing the common bile duct. Okay, this one, CBD. Okay, CBD, common bile duct and main pancreatic duct. Okay, both open, both finally, okay, open into second part of duodenum only. What is the mucosal projection produced by the opening of these two structures? Yes, both open into the major duodenal papilla. Okay, the common bile duct and main pancreatic duct both open into the major duodenal papilla, which is a feature of second part of duodenum. Okay, and this major duodenal papilla is located approximately 8 to 10 centimeter distal to the pylorus of stomach. Okay, it is located, major duodenal papilla is located 8 to 10 centimeter distal to the pylorus or pyloric end of stomach. Okay, and just 2 centimeter proximal, okay, just 2 centimeter proximal to the major duodenal papilla, we have the location of what? Minor duodenal papilla. Okay, this is the minor duodenal papilla. Okay, you know the location of minor duodenal papilla, 2 centimeter proximal to the major duodenal papilla. And what is the importance of minor duodenal papilla? Yes, it receives the opening of what? Exactly, minor pancreatic duct, otherwise called as accessory pancreatic duct, opens. Okay, accessory pancreatic duct opens into the minor duodenal papilla. Fine. And you can see there are numerous small ducts which open into the main pancreatic duct at right angles. Okay, to produce the herringbone pattern. Okay. Yes. And finally, coming to the topic, arterial supply of the pancreas. Okay, blood supply or arterial supply of the pancreas. Okay, I have told you yesterday the body and the tail of pancreas, they are supplied by the pancreatic branches of the splenic artery. Okay, Fine. What about the head and neck of pancreas? You know the four parts of the pancreas, isn't it? Head and neck of pancreas. Then we also have the body and the tail of pancreas. Okay. So out of these four parts, as we studied earlier yesterday, the body and tail of pancreas both are supplied by pancreatic branches of splenic artery, by the numerous pancreatic branches of splenic artery, isn't it? And the largest pancreatic branch of splenic artery, is named as arteria pancreatica magna. Arteria pancreatica magna. Magna means largest. Okay, fine. What about the head and neck of pancreas? Yes, the head and neck of pancreas, they are located within the C-shaped concavity of duodenum, isn't it? So they are supplied by the anastomosis. Okay, they are supplied by anastomosis formed between branches of superior and inferior pancreatico-duodenal arteries. The superior and inferior pancreatico-duodenal arteries, they will be anastomosing with each other, and those anastomosis will be providing blood supply to the head and neck of pancreas. Okay, and I hope you will be knowing superior pancreatico-duodenal artery is a branch of gastroduodenal artery. Okay, and what about the inferior pancreatico-duodenal artery? Inferior pancreatico-duodenal artery is a branch of superior mesenteric artery. Okay, so some other details related to the gastroduodenal artery, superior mesenteric artery, we will discuss in some other session. Okay, when we talk about the celiac trunk, superior mesenteric artery and all. Okay, so this is about the arterial supply of pancreas. Okay, head and neck are supplied by the branches of superior inferior pancreatico-duodenal arteries. Body and tail of pancreas are supplied by the pancreatic branches of splenic artery. Veins will be corresponding. Okay, when you talk about the venous drainage of the pancreas, the veins will be corresponding to the arteries. Okay, they will directly or indirectly, the veins will drain into the portal system, portal circulation. Directly or indirectly, okay, they will drain into the portal system. Okay, either into the superior mesenteric vein or splenic vein or portal vein, whatever. Okay. Fine. So that's the end of today's session. Okay. Thank you all.
So good evening, everyone. So today we'll be talking about the visual pathway and the important points in the visual pathway. Okay, relevant from the exam point of view. So first, let's start with the So visual pathway, we have to know the first order neuron, the second order neuron, and the third order neuron. Okay. So you remember the first order neuron begins from the bipolar cells. From the bipolar cells, the second order neuron is in the ganglion cells. The third order neuron is in the lateral geniculate body. Okay. So the optic nerve is nothing but the second order neurons. It's nothing but the collection of ganglion cells. So it is a second order neuron which transmits inputs to the visual pathway. So from the optic nerve to the occipital lobe, we have the visual pathway. Okay. So third order neurons, I told you, is the lateral geniculate body. So let's study about the lateral geniculate body briefly. Okay. So you can see that the lateral geniculate body, it has 6 layers. Okay. The first 2 layers, which contains the larger cell, is the magnocellular pathway. The 3 to 6 layers, which contain the smaller cells, is the parvocellular pathway. Okay. And what happens is there is a crossing over. Okay. 1, 4, 6. So 1, 4, 6, they cross over. You can see that the fibers from 1, 4 and 6, they cross over to the opposite side, while 2, 3, 5 supply the impulses to the same side. Okay, 1, 4, 6 cross over, 2, 3, 5 supply the same side. So coming to the magnocellular pathway. So what is magnocellular pathway? I told you the larger cells in 1 and 2. So the input for the magnocellular pathway is by the gamma ganglion cells. The input is mainly for the gamma ganglion cells. So magnocellular pathway, it carries the signals for detection of motion and flicker. So classical of M for magnocellular pathway, M for motion. Okay, so that's how we remember. So it is mainly useful for the detection of motion and any flickering movement. Remember, the magnocellular pathway is colorblind and very poor in point-to-point transmissions. The point-to-point transmission is mainly a function of the parvocellular pathway. How do you remember? P for parvocellular pathway, P for point-to-point spatial information. And the input for the parvocellular pathway comes from the alpha ganglion cells, and it mainly transmits the color vision and the point-to-point spatial information. So coming to the pupillary light reflex. So what happens whenever the light is shown on the pupil, there is a constriction of the pupil on the same side and on the opposite side. Okay. So this is mainly the pupillary light reflex. So we'll be studying about the pathway which mediates this. So the impulse is transmitted via the optic nerve. Okay. From the optic nerve, it transmits to the pretectal nucleus. Okay. The pretectal nucleus, and from the pretectal nucleus to the Edinger-Westphal nucleus. Okay, so they ask you which is the center for the pupillary light reflex. It is the Edinger-Westphal nucleus. Edinger-Westphal nucleus, and from the Edinger-Westphal nucleus, the preganglionic parasympathetic nerve fibers, they travel via the third cranial nerve and supply the ciliary ganglion. Okay, the preganglionic parasympathetic. So remember, the sphincter receives the parasympathetic innervation and the dilator receives the sympathetic innervation. So in the pupillary light reflex, what we are studying is the pathway which mediates the sphincter reflex. Okay. So the preganglionic parasympathetic nerve fibers arising from the Edinger-Westphal nucleus, they terminate in the ciliary ganglion. So from the ciliary ganglion, you have the postganglionic parasympathetic nerve fibers. The postganglionic parasympathetic nerve fibers travel via the posterior ciliary nerves and supply the constrictor muscle or the sphincter pupillae. This causes the pupillary constriction. This is the main pupillary pathway. Okay. So in pupillary pathway, you should know what is the swinging flashlight test. Okay, so what happens whenever there is a defect in the optic nerve on the same side? So whenever the pupil, when the light is shown from one eye to the other, there is a contralateral dilatation of the pupil, which is also known as the Marcus gun pupil. Marcus gun pupil. So the Marcus gun pupil is the relative afferent pupillary defect, which is which is picked up on a swinging flashlight test. The swinging flashlight test helps to see the dilatation of the pupil. Instead of constriction, the pupil will dilate in a swinging flashlight test in a Marcus gun pupil or a relative afferent pupillary defect. Next, coming to the sympathetic pathway. I told you the sympathetic pathway is mainly mediates the function of the dilator pupillae. So sympathetic pathway is very important when we study about the Horner syndrome. Okay, so again, when we come back to Horner syndrome, we'll be discussing this in detail. Here, I'll just mention you the neurons which are involved. Okay, so the primary neurons are the first order neurons. It starts from the posterior hypothalamus. From the posterior hypothalamus, it descends downwards to the ciliospinal center of Budge. So this ciliospinal center of Budge is formed by the C8 to T1 rami, ventral rami of C8 to T1. So from the ciliospinal center of Budge, the second order neurons which arise, they wind around they come very close to the contact of the apex of the lung, and they come and move along the internal carotid artery, and they terminate in the superior cervical ganglion. Superior cervical ganglion. Okay. So primary neurons terminate in the ciliospinal center of Budge. The second order neurons terminate in the superior cervical ganglion, again close to the apical pleura. The second order neurons are very close to the apical pleura. So this third order neurons, it starts from the superior cervical ganglion and it ascends via the internal carotid artery. They ascend via the internal carotid artery into the skull to join the ophthalmic division of the fifth cranial nerve. It joins the ophthalmic division of the fifth cranial nerve, and from here it supplies via the ciliary ganglion, and from the ciliary ganglion through the nasociliary nerve it reaches the dilator pupillae via the long ciliary nerve. Okay, so through the nasociliary nerve it reaches the dilator pupillae through the long ciliary nerve. Okay, so this is the sympathetic pathway. So when we're discussing about Horner syndrome, I'll talk about the tumors of the apex of the lung, how it compresses on the sympathetic pathway, and aneurysm, how does it cause a painful Horner's. Okay, all that we'll be discussing in detail when we talk about Horner's. So you should know about the sympathetic pathway. So first order neurons, the second order neurons, and the third order neurons. Okay, so remember the ciliospinal center of Budge, which is formed by C8 to T1. Okay, so now for quickly coming to the questions, the primary visual cortex is located in the parieto-occipital sulcus, superior temporal sulcus, posterior part of the calcarine sulcus, and the central sulcus. Always remember it is the posterior part of the calcarine sulcus. The area 17, okay, typically which is located in the calcarine sulcus in the occipital lobe, of the brain. If they ask you which is the accessory visual areas, it is the areas 18 and 19. So the primary visual area is the area 17 of the Brodmann area, which is located, it occupies the upper and the lower lips of the calcarine sulcus on the medial surface of the cerebral hemisphere. Okay, so the primary visual cortex is Brodmann area 17, and the visual association area is extensive, which includes the whole of the occipital lobe, the adjacent posterior part of the parietal lobe. This cortex is involved in the representation of recognition of objects, the perception of color, the depth perception, the motion, and other aspects of vision. Okay, so the visual association area aids the primary visual cortex function. Okay, mainly for pattern recognition, color recognition, depth recognition. Okay, and also motion. All this is assisted by the accessory area. So vitamin B12 deficiency causes a bitemporal hemianopia, binasal hemianopia, heteronymous hemianopia, and centrocecal scotoma. So always remember, if it's a toxic amblyopia or if it's because of a nutritional amblyopia, nutritional deficiency, typically results in a centrocecal scotoma. So the answer is a centrocecal scotoma. It is an important cause for a nutritional optic neuropathy. Vitamin B12 deficiency is an important cause for a nutritional optic neuropathy. The color best appreciated by the central cones in the foveomacular region. I told you the foveomacular region is blue blind. So the cones which are best appreciated is the red and the green cones. Okay, so always remember the fovea is blue blind. Fovea is blue blind. So optic nerve, I told you the first order neurons is the bipolar cells. Then the second order neurons is the ganglion cells. The third order neurons is the lateral geniculate body. So the optic nerve constitutes the second order neurons. So it is formed by the axons of the ganglion cells. Since the ganglion cell is the second order neuron of the visual pathway, the optic nerve forms the second order neuron. So which of the following is not involved in the vertical eye movements? Frontal eye fields, PPRF, interstitial nucleus of Cajal, and trochlear nucleus. Okay, remember the parapontine reticular formation, or the PPRF, what we call, is the horizontal gaze center. So this, in the subsequent presentations, we'll be talking about the horizontal gaze centers, the vertical gaze centers, and 1.5 syndrome, okay, 8.5 syndrome, and INO, all that will be discussed in the subsequent classes. So remember, the horizontal gaze center, important is the PPRF. The parapontine reticular formation is the horizontal gaze center. It does not contribute to the vertical eye movements. So the supranuclear control of the vertical saccades, it originates from the frontal eye field. Remember, the ultimate control or the cortical control is from the frontal eye field, okay, in the superior colliculus. So they project to the neurons in the RIMLF. So the vertical gaze center, if they ask you which is the vertical gaze center, the vertical gaze center is the RIMLF, or the rostral interstitial medial longitudinal fasciculus, along with the nucleus of Cajal. If they ask you which is the horizontal gaze center, the horizontal gaze center is the PPRF. So this is very important. So vertical gaze center and the horizontal gaze center, a lot of questions have come and will also come in the future. And from the RIMLF on to the nuclei of the third and the fourth cranial nerve. The interstitial nucleus of Cajal is also involved in the vertical pursuit movement. So along with RIMLF, nucleus of Cajal. PPRF controls the horizontal eye movements. So with this, we'll finish the class for today. For tomorrow, we'll discuss about the visual field path, okay, visual field defects. So the various visual field defects from the optic nerve to the occipital cortex, we'll discuss in detail tomorrow.
Okay, so good evening. Today we'll continue with the next thing. Okay, so yesterday we finished about type 1 hypersensitivity reaction, isn't it? Now we will see what is type 2 hypersensitivity reaction and the diseases associated with it, because this is also a potential question. See, amongst the 4 hypersensitivity, one is confirmed, so we'll just go through all the 4. So when it comes to type 2 hypersensitivity reaction, type 1 was IgE mediated, and it was some mast cells were the principal cells, and in the late phase it was eosinophils, isn't it? So type 2 hypersensitivity reaction basically is antibody mediated. So this antibody mediated, okay, it can cause any of these 3 mechanisms, A, B, and C. Again, images from Robbins. Okay, so what it can do is it can cause this antibody which is there. This antibody can be directed against the cell itself or the tissue itself, that is autoantibody, or this antibody can be directed against some other exogenous substances which is attached onto the cells. Okay, say for example any microbe like that. Okay, so it can be autoantibodies against the cell or the tissue, or it can be against the exogenous substances. Fine. So there are 3 mechanisms through which it can cause damage to the cell. First thing is these antibodies, okay, along with the complements like C3b, okay, they will cause opsonization of the cells of the tissue, and later they will recruit phagocytes, and these phagocytes will destroy the cell which is coated with complements and antibody by phagocytosis. That is the first way it is going to destroy the tissue. So first principal mechanism through which type 2 hypersensitivity reaction occurs is by opsonization mediated phagocytosis. Opsonization mediated phagocytosis. So what are the opsonins here? Complements, especially C3b and the antibodies. Okay, the second mechanism is complement mediated and antibody mediated inflammation. It will recruit few cells, okay, in the tissue, in any tissue, wherever the antibodies go and bind to the specific antigens in the tissue. Say for example basement membrane. Okay, so when they go and bind, when these antibodies come and bind on the, say for example, this is the basement membrane. So when they come and bind, what will happen is they will recruit the inflammatory cells. Okay, and then these inflammatory cells are going to produce cytokines, okay, and reactive oxygen species which are going to damage the tissues. That is the second thing which can happen. The third thing is antibody mediated cellular dysfunction. One best example for this is antibodies which are directed against the receptors. For example, neurotransmitter receptors. Okay, say for example, acetylcholine has to act on the ACH receptors, but when there are antibodies which are produced against this ACH receptors, they come and bind to these receptors and prevent acetylcholine from binding. This is an important example, myasthenia gravis. Or the antibodies can bind to TSH receptors and long acting, so they will cause Graves' disease. So these are the examples. These are the mechanisms through which type 2 hypersensitivity reaction functions. Now, coming to the most important sections, we will see what are the diseases associated with type 2 hypersensitivity reaction. Okay. Fine. So first thing I want you to remember is, they will give you a case scenario and they will ask you what type of hypersensitivity reaction it is. So autoimmune hemolytic anemia and autoimmune thrombocytopenic purpura, these both come under type 2 hypersensitivity reaction, because here to the cells the antibodies are going to come and bind, and then complement mediated lysis of the cell or the lysis of the cell through inflammatory cells should occur, isn't it? So here basically in hemolytic anemia and thrombocytopenic purpura, the antibodies come and bind to platelets or RBCs. Okay, once they are bound, they will mediate complement mediated lysis. So important examples, okay, is autoimmune hemolytic anemia and autoimmune thrombocytopenic purpura. What are the antigens to which the antibodies bind? Say for example, blood group. So immediate transfusion reactions, which is usually a clerical mistake. Okay. And next one is autoimmune thrombocytopenic purpura, when there are antibodies which are directed against glycoprotein 2B3A. Okay, so complement mediated lysis or opsonization and phagocytosis mediated lysis. Okay. So how will they present with autoimmune hemolytic anemia? Will present with hemolysis and anemia. ATP will present with bleeding. Okay, the next important example is pemphigus vulgaris, where the antibodies are directed against desmogleins. Okay, they are very, very important. These desmogleins are the intercellular junctional proteins. Intercellular junctional proteins. When these antibodies come and bind against desmogleins, that is when there is disruption of these junctions and there is the cells give away those contact and leading to bullae formation. Okay, and the next important example is vasculitis mediated by ANCA. Okay, so vasculitis, you have to remember. Very, very important is Goodpasture syndrome, where the antibodies are directed against basement membranes of the kidney glomeruli and lung alveoli. Okay, so complement and the antibodies will recruit inflammatory cells and damage the basement membrane of the kidney and the lung alveoli, leading to nephritis and lung hemorrhage. Very, very important this is. Then acute rheumatic fever, where the antibody cross reacts with the myocardial antigen, that you all know, that you have to remember. Now coming to the most important thing, myasthenia gravis, where antibodies are directed against acetylcholine receptors, and Graves' disease, where antibodies are directed against TSH receptors. Okay, then pernicious anemia, intrinsic factor, antibodies are directed against intrinsic factor of gastric parietal cells. Okay, so these are the important examples of type 2 hypersensitivity reaction. So you have to remember this. So type 2 hypersensitivity reaction, it can occur through 3 processes. One is opsonization and phagocytosis. See, all these tables are from Robbins. You just have to flip through the pages. Okay, opsonization and phagocytosis. See, antibodies can be directed against, autoantibodies directed against the tissue and the cells itself or exogenous substance. Okay, and opsonization and phagocytosis is one mechanism. Next mechanism is complement and antibody mediated inflammation. The third is when the antibodies are directed against the receptors. So 3 examples in hematology you have to remember: autoimmune hemolytic anemia, autoimmune thrombocytopenic purpura. In autoimmune hemolytic anemia, it is direct. Example is red cell membrane proteins, be it blood group antigens or I antigen. In thrombocytopenic purpura, it is directed against glycoprotein 2B3A proteins. Okay, and pernicious anemia, where it is directed against intrinsic factor and the mechanism of synthesis of the cells. The vitamin B12 absorption is affected. Okay, so 3 in hematology. In skin, dermoglenin, when it is directed against dermoglenin, an intercellular junctional protein, it leads to pemphigus vulgaris. So pemphigus vulgaris, the mechanism of action is type 2 hypersensitivity reaction. Okay, Goodpasture syndrome, where it is very, very commonly asked, directed against basement membrane of the renal glomeruli and lung alveoli. Okay, then myasthenia gravis and Graves' disease, it is the mechanism through which the receptors, it is going to act on the receptors. Myasthenia gravis, the antibodies are going to act on ACH receptors. Graves' disease, it is going to act on what? It is going TSH receptors. So these are the disorders you have to remember and under type 2 hypersensitivity reaction. So we'll go into the question. A 28-year-old man has hemoptysis and hematuria. So the lungs and the renals are affected for the past 2 days. On physical examination, his temperature is 36.8 normal, pulse is 87 normal, respiratory rate is normal, and blood pressure is a little on the higher side. Okay, it is on the moderate hypertension side. And laboratory study shows creatinine is 3.8 abnormal, blood urea nitrogen is 35 milligram per deciliter. Okay, urine analysis shows 4 plus hematuria abnormal, 2 plus proteinuria abnormal, and no glucose. Okay, so there is something. So there is abnormality in the lungs and the renals. So this itself should give you some clue that you're dealing with something related to these two systems. A renal biopsy specimen examined microscopically shows glomerular damage and linear immunofluorescence with labeled complement. That means what they are trying to tell you is on microscopic examination, okay, the glomerulus is damaged, and when you see immunofluorescence, there is linear deposition. So usually when there is linear, in the renal classes, I have always told you, when there are granular humps and bumpy deposition, it is antigen antibody complexes which are depositing. Okay, when it is uniform linear deposition, that means to something indigenous tissue, say for example basement membrane, just antibody is coming and depositing uniformly. So whenever it is antigen antibody complex, they're planted in the tissue, so they will deposit in lumps. Okay, but whenever it is just antibody coming and depositing on the antigens, they will linearly deposit. Okay, so deposition of C3 and IgG antibody. Okay, so this is characteristic. We will go through it in detail in your renal classes. So C3 and IgG antibody deposition on the glomeruli causing damage, and along with that there is hemoptysis. It is giving you a diagnosis of Goodpasture syndrome. So which of the following autoantibodies has the greatest specificity for this patient? Okay, so it is anti-basement membrane antibody, that is collagen 4 of the basement membrane. The antibodies are directed against collagen 4. It is type 2 hypersensitivity reaction. See, anti-cardiolipin isn't seen here in APLA. Anti-double stranded DNA is seen in SLE. Anti-histone antibodies is seen in drug-induced lupus. Anti-SSA is seen in Sjogren's syndrome. Anti-ribonucleoprotein is seen in multiple connective tissue disorders. Okay, this is one question, very important question. Next question is, laboratory tests are ordered for 2 hospitalized patients. During phlebotomy procedure, the samples drawn from these patients are mislabeled. So clerical mistake is happening here. One of the patient receives blood transfusion later that day. So they're interchanged. Okay, within 1 hour after the transfusion of the packed RBCs, the patient becomes tachycardic, hypotensive, and passes pink colored urine. In the transfusion medicine classes, I've already told you this is an early hemolytic reaction. Okay, immediate hemolytic reaction which is occurring, which is very rare because we checked it, but clerical mistakes can happen. So passing pink colored urine means there is hemoglobinuria because of hemolysis. Okay, so which of these following mechanism is most likely to be responsible? So now what we know with this history, that the wrong blood group is given. So the donor's antibodies have reacted with, the recipient's antibodies have reacted with the donor's RBC, leading to breakdown of RBCs, hemolysis, intravascular hemolysis. And this intravascular hemolysis, what is it going to be presenting to you as? Pink colored urine, hemoglobinuria. So which of the following is the mechanism? They have asked the mechanism. So we'll see the options. Antibody dependent cellular cytotoxicity by natural killer cells. Antigen antibody complex deposition in the glomeruli, ruled out. So this option is ruled out. Complement mediated lysis of red cells. Okay. Mast cell degranulation, ruled out because it's type 1 hypersensitivity. Release of tumor necrosis factor. No way tumor necrosis factor is related in any of these reactions. So you have doubt in these both, but I have already mentioned in RBCs, platelets and all, it is usually complement mediated lysis. It is complement mediated lysis. Immediately membrane attack complex is formed. As soon as the antibodies bind to the RBC, membrane attack complex complements come in and membrane attack complex is formed and there is lysis of the cell. Okay, so these are the questions which you can expect. Okay, so you have to remember this set of disease: autoimmune hemolytic anemia, autoimmune thrombocytopenic purpura, and pernicious anemia in hematology come under type 2 hypersensitivity reaction. Graves and myasthenia gravis repeatedly asked, they come under type 2 hypersensitivity reaction. Good pastures is one stock question for examiners, so that comes under type 2 hypersensitivity reaction. Okay, so these are the three mechanisms through which there is damage. Okay, thank you.
Good evening, friends. We'll discuss atypical mycobacteria and Mycobacterium leprosy today. We have finished Mycobacterium tuberculosis discussion yesterday. We'll start with atypical mycobacteria. So the question which has been asked recently is, rapidly growing atypical organism which is involved in lung infection. This question is asked in AIMS 2013. So we'll read the classification later. First, we'll know the answer for this question. So rapidly growing atypical mycobacteria which is involved in lung infection. So your answer is Mycobacterium abscessus. Okay. So your correct answer is Mycobacterium abscessus. Second question will go, how we classify atypical mycobacteria. You get lot of question on this. So Runyon classification we follow, which is based on pigment production and rate of growth. Okay, so you have 4 groups: photochromogen, okay, non-photochromogen, scotochromogen, and rapid grower. So the name indicates photochromogen, they will produce pigment after exposure to light. Okay. Scotochromogen, they produce pigment in dark. Okay. Non-photochromogen, name indicates no pigment production. Rapid grower, they grow within less than 7 days. Okay. So we say them rapid grower, right? So photochromogen are which are responsible for your pulmonary, skin, systemic, and lymph node infections. Scotochromogen, which produces pigment in dark. Habitat is water, soil, and fomite. Example for scotochromogens is Mycobacterium scrofulaceum, and they are responsible for cervical lymphadenitis in children. Okay. Non-photochromogen, no pigment production. In that, you have Mycobacterium intracellular complex, avium, and xenope. The most common habitat is soil, seawater. They causes pulmonary, GIT, renal, epididymis infection. Rapid grower, which grows within less than 7 days. Your Mycobacterium fortuitum is rapid grower. Okay, this habitat is water, soil, animal, and it causes various renal, pulmonary, gastrointestinal infection. Now coming to this question has been asked in some state entrance, like which among them is pigment producing atypical mycobacteria. So we read, right? Photochromogen produces pigment in light. Scotochromogen produces pigment in dark, right? So we'll know the example of photochromogen. So your Mycobacterium marinum, simiae, Atypicum, Kansasi, these are your photochromogen. So which is scotochromogen, which produces pigment in dark. So scrofulaceum, Suzelli, Gordoni, these are your scotochromogen. Okay, so please remember the name for photochromogen and scotochromogen. They produces pigment in light and dark respectively. Now, yes, different question has been asked. Which is saprophytic bacteria, mycobacteria? So Mycobacterium feli, which is extracted from grass, smegmatis mycobacterium, which is extracted from urine. So this comes under mycobacteria, feli from grass, smegmatis from urine. Which causes fish tank granuloma? Yes, this has been asked previously, or it can be asked which causes swimming pool granuloma. So marine, okay, from that you create that this swimming granuloma, or okay. Now coming, which causes cervical lymphadenopathy. Mycobacterium scrofulaceum causes cervical lymphadenopathy, which is scotochromogen. Which mycobacterium can be seen in tap water? Mycobacterium gordoni can be seen from or isolated from tap water. Which is Mycobacterium avium intracellular complex. It is Mycobacterium avium and Mycobacterium intracellular together is called Mycobacterium avium intracellular complex. Why they are important? Because they are where CD4 count drops below 50. Okay, so when CD4 count is less than 50, Mycobacterium avium intracellular complex infection is very common. Okay, this is also called as battery bacilli. This has been asked. What is the other name of battery bacilli, or which is called battery bacilli? Your Mycobacterium avium intracellular complex is called battery bacilli. Which causes Bruley ulcer? ulcerans. Mycobacterium ulcerans causes Bruley ulcer. Why they causes ulcer? Because they produces one toxin which is called mycolacton, which is responsible for ulceration. Okay. Which causes post-traumatic abscess or injection abscess? Mycobacterium fortuitum, very favorite. Okay. Okay, injection abscess, Mycobacterium fortuitum. Which causes pulmonary infection, which has been asked? Mycobacterium abscesses causes. There are various causes of pulmonary infection. One of more common is Mycobacterium abscesses. Now coming to next topic. So in atypical, we read about which is atypical mycobacteria, their classification on the basis of pigment production and growth rate. Then we came to know about various kind of, which is one-liner question like Bruley ulcer, fish tank granuloma, battery bacilli. These all has been asked previously, and this is important for your upcoming entrances also. Now coming to Mycobacterium leprae, very common, we know all, right? Common cause, which is causes leprosy. Okay, so being a bacteria, it cannot be cultured in artificial culture media. How we culture? We use 9-banded armadillo or footpad of mice. Okay, so option you have to select 9-banded armadillo, footpad of mice is way of culturing of Mycobacterium leprae. Okay, now how appearance, what appearance? We saw Mycobacterium tuberculosis appearance on Zealand cell staining, right? Acid fast staining. They are thin, long, slender, straight or slightly curved bacilli. Mycobacterium tuberculosis. How the Mycobacterium leprae looks? They are little shorter, thicker, and they are present in a stack of, okay, stack of bacilli. So we say it as a cigar bundle appearance. They are not present singly, but they are present one above another. So we say it as a cigar bundle appearance. And we know that they are also acid-fast organism. Okay, they are acid-fast organism. What acid-fast staining we do? Modified acid-fast staining. So why we say modified acid-fast? Mycobacterium tuberculosis, we remember we have used 20% sulfuric acid as a decolorizer. Here we are using how much percentage? 5% of sulfuric acid for decolorization. So it is, we are doing modified acid-fast staining. How much percentage? 5% of sulfuric acid. And these lepra bacilli is bounded with lipid-like substance, which we say globi, inside a foamy macrophages, which together we say it as a Virchow lepra cell. So nothing but these are bacilli, acid-fast bacilli inside macrophages. Excuse me. What is a generation time? We know the generation time of gram-positive cocci is much lower, gram-negative cocci is little higher. Gram-positive cocci is little longer, gram-negative bacilli is shorter, and the generation time of lepra bacilli is one of the highest generation time, that is 12 to 13 days. Your Escherichia coli generation time is 30 minutes. You can imagine how long it takes for lepra bacilli to, from one bacilli to become 2 bacilli, right? That is called generation time, multiplication time. So that is your 12 to 13 days in Mycobacterium leprae. So this has been asked in your some state entrances, what is the generation time? So you should be knowing. Now, the question which has been asked in PGI 2017 about the clinical presentation of leprosy patient, how they will present, what will be their clinical presentation? Do they have saddle nose? Do they have small earlobe, ptosis, leonine facies, lag of thalamus? So we'll go for answer. So answer for this is, your answer, saddle nose is correct. Okay. Now, leonine facies is correct. Lag of thalamus is correct. So we don't see small earlobe. Why? Because earlobe will become thicker, right? So we see enlarged earlobe, not small earlobe. Okay. ptosis, oculomotor nerve involvement is not there, so we don't see ptosis. So small earlobe you are not going to see, ptosis you are not going to see. You are going to see saddle nose, leonine facies, and lag of thalamus. So we will see the picture. What happens? Loss of eyebrow will be there. Nasal bridge collapse will be there. Lumpy and large earlobes will be there. This is called leonine facies in lepromatous leprosy. Okay, so leprosy bacilli, they grow better in cooler area of the body, like your skin, your nose, right? Nerves. So these all are cooler area where they grow. Where lepra bacilli cannot grow, lepra bacilli cannot infect which all organ? So your ovary, okay, your scalp, CNS, lung, okay, okay, axilla, groin, these all which are warmer area of the body. Okay, so these all area does not get infected by leprosy bacilli. So ovary, central nervous system, your lung, warmer area, moist area like axilla does not get infected. Which is the most common organ or area gets affected? So your skin, nose, nasal septum, nerve, which are little cooler area of the body. Okay. So what are the classification, bacteriological classification we use? Pauci or multibacillary. Pauci bacillary is non-infectious, less than, it is mainly tubercular type, and less than 5 lesions you see. Normal CMI, cell-mediated immunity, will be almost normal, okay? And lepromin test will be positive in this. Okay. How you treat? Treat with dapsone, rifampicin, dapsone 100 milligram daily, rifampicin 600 milligram once per month under supervision. Multibacilli, yes, this is infectious and lepromatous. Pauci bacilli was non-infection, tuberculoid, and more than 5 lesions will be there. Cell-mediated immunity will be lower in this, and lepromin test negative. So lepromin test will be negative. Either you say multibacillary leprosy or lepromatous leprosy. Here, dapsone 100 milligram daily, rifampicin 600 milligram once per month, and clofazimine 300 milligram once per month, followed by 50 milligram daily has to be the treatment of the paucibacillary and multibacillary. Okay, what is the differences between tuberculoid and lepromatous leprosy? So you can see these the feature of tuberculoid leprosy. You can see well demarcated patches are there. Okay. Dry patches will be there. There is no leonine facies, no claw-shaped hand, no earlobe enlargement. Good immune response of the host will be there. Whereas lepromatous leprosy, you have claw-shaped hand, you have enlarged earlobe, saddened nose, and as we read, CMI will be low resistance will be there. Okay. So what is type 1 and type 2 lepra reaction? Is because of type 1 helper cell, type 2 is type 2 helper cell. Type 1 reaction is delayed type of CMI, type 4 cell mediated. Type 2 lepra reaction is type 3 hypersensitivity reaction, which is immune complex mediated reactions. So which all clinical type you see this type 1 lepra reaction. So you see in tuberculoid, borderline tuberculoid leprosy. This mainly type 2 you see in lepromatous leprosy or borderline lepromatous leprosy. This happens because of previous treatment. It can be happen because of previous treatment or not. Okay. In this, you see types is your erythema nodosum leprosum. So ENL reaction you see is type 2 reaction, which you see in lepromatous leprosy. Okay. How you treat them? So type 1, mainly NSAIDs or steroid will be there. Here you have, apart from steroid, you clofazimine and thalidomide is the treatment for type 2 lepra reactions. Okay, so type 1 is type 4 type of hypersensitivity. Type 2 is type 3 type of hypersensitivity, which is immune complex mediated. Type 1 mainly we see in tuberculoid variant, tuberculoid leprosy or borderline tuberculoid, and type 2 we see in lepromatous, borderline lepromatous, and erythema nodosum leprosum you see in type 2 reactions. Okay, treatment for type 1, you will be having NSAIDs, steroids. Type 2, apart from these, you will have clofazimine and thalidomide. So I conclude today's discussion. We'll meet again with some important topics in microbiology. Till then, thank you.
Good evening, everybody. So yesterday we had seen about autonomic nervous system main functions with respect to sympathetic and parasympathetic system. I just want to have a quick look at yesterday's presentation. One thing I wanted to clarify with you people before we start today's class. See, with respect to the ciliary epithelium, I told you that beta 2 receptors are present and alpha 2. Beta 1 is also present in ciliary epithelium. Remember it. With respect to alpha, I told you alpha 1 selective agonists will be used because see, this difiveprin is a prodrug of epinephrine. So this is not alpha 1 selective. So the alpha 1 selective will be apraclonidine and brimonidine. Okay, remember this apraclonidine and brimonidine because yesterday I had by slip shot I have told that alpha 1 selective is dipinephrine. No, dipinephrine is alpha 1 and 2 and also on beta also it can act. But alpha 1 selective is apraclonidine and brimonidine. I missed that. So I just wanted to clarify that. Okay, now let's go to today's class. So today's class will be on cholinergic drugs. Today's class will be on cholinergic drugs. So when coming to coming to cholinergic drugs, we have direct acting agents and indirect acting agents. Remember this. We have two things, direct acting agents and indirect acting agents. With respect to direct acting agents, we have acetylcholine, pilocarpine, methanacol, methacholine, and carbachol. Okay. With respect to indirect acting, it is nothing but acetylcholinesterase inhibitor in the postsynaptic cleft. The acetylcholine will be inhibited by your metabolized by acetylcholinesterase. If the acetylcholinesterase is inhibited, then acetylcholine will increase. Reversible, irreversible. Irreversible are only organophosphates and carbamates. Remember this. Irreversible are only organophosphates and carbamates. A recent MCQ was also asked in AIMS in a set November 2021. Last week it was held. Organophosphatase is what type of inhibitor? It is a irreversible inhibitor. Very simple question it was asked. Anyways, we'll be doing the recall. That time we'll have this question. Okay. With respect to reversible, we have lipid soluble, water soluble. Lipid soluble, we have physostigmine. Water soluble, we have neostigmine and pyridostigmine. Remember it, lipid soluble drugs can cross blood-brain barrier. Water soluble drugs cannot cross blood-brain barrier. Remember this. So physostigmine will cross, neostigmine and pyridostigmine will not cross. There are 4 more drugs in lipid soluble, which is called tacrine, donazepam, rivastigmine, and galantamine. This always, you should remember this as a pair. TDRG. Okay. Tacrine, TDRG. Okay. Tacrine, donazepam, rivastigmine, and galantamine. You can remember with a mnemonic, grand touring doctor. Okay. A doctor goes on a tour. Che Guevara was a doctor. He went on a tour all around Argentina. So, grand touring doctor. Galantamine, tacrine, donazepam, and rivastigmine. All these are used for Alzheimer's disease because Alzheimer's disease, the ACH levels are very low. This can be given to increase the ACH levels to cure Alzheimer's disease. Now, we'll go to direct acting agents. Acetylcholine is not as such used in therapeutically. You don't give pure acetylcholine because it is metabolized very quickly, not effective by IV route. So this is very important. Methacholine, M for M. Remember myocardium. It has action on myocardium, maximum action, M for M. This methacholine is also used in asthma testing. So when the patient clinically has no symptoms of asthma, but he has an hyperreactive bronchus, the physician suspects, then you give methacholine inhalation or you give methacholine IV also you can give. Suddenly the patient will start wheezing. Bronchoconstriction will happen. So methacholine challenge test. Methanacol. bladder, B for B. It has got no nicotinic activity. Remember this. Methanocol has maximum action on bladder, no nicotinic activity. Pilocarpine, it is a meiotic action is there because parasympathetic, cholinergic, eyes, meiosis. Okay. By short duration of action, very short duration of action. That's why you don't use it in glaucoma nowadays, because there's fluctuations in intraocular pressure is noted. Okay. Carbachol. Common activity on muscarinic and C for C. Common activity on both muscarinic and nicotinic receptors. There is one more drug, cevimeline. This can be used in the treatment of dry mouth for Sjogren's syndrome or after radiotherapy. Also, pilocarpine can also be used. Both pilocarpine and cevimeline can be used for dry mouth. Okay. Now, going to indirect acting. First, we'll see reversible. Of course, ACHC inhibitor, so it increases the acetylcholine action. Physostigmine, it's a tertiary, I told you, lipid soluble, crosses BBB. All that grand touring doctor, Alzheimer's drugs, staccarin, donosable, rivastigmine, galantamine can also cross your BBB. It is effective only orally. Remember this, it is effective only orally. It is used in glaucoma as a meiotic. Main thing is it is used as an antidote for belladonna poisoning. That is nothing but atropine poisoning. Okay. Neostigmine. It's a quaternary compound, does not cross BBB. Direct nicotinic muscular receptor action in musculoskeletal action. Okay, skeletal muscles. Where it is used, that is very, very important. It is used in myasthenia gravis, cobra bite treatment, paralysis. So cobra bite treatment, you use it. Post-operative paralytic ileus, you can use it. Atonic urinary bladder, you can use. You can use for reversal of competitive skeletal muscle relaxants. You cannot use for non-competitive skeletal muscle relaxants. We can use for competitive skeletal muscle relaxants. When you give a competitive skeletal muscle relaxant, you can use neostigmine to reverse it. Okay. Now, remember this, myasthenia gravis, cobra bite, post-operative paralytic ileus, atony of urinary bladder, reversal of competitive skeletal muscle relaxants, not used for non-competitive, not used for non-competitive. Remember this, okay? Pyridostigmine is longer acting than neostigmine. For all indications of neostigmine, you can use pyridostigmine also. Where one more use is therapeutically is atropine. It can be added to atropine to reduce the muscarinic effects. Atropine can be added to it to reduce them because it is longer acting, no? So for neostigmine, atropine is not required, but for pyridostigmine, whenever you use, atropine needs to be added. Now coming to edrophonium, it is a shortest acting. Remember this is a shortest acting reversible anticholinesterase inhibitor. It is used in the diagnosis of myasthenia gravis. So you give tensilon, 2 mg, it's called tensilon test. If the patient has myasthenia gravis, the weakness will improve. But if the patient has cholinergic crisis, the weakness will worsen. So it is used to differentiate myasthenia gravis from cholinergic crisis. Okay. And also to diagnose myasthenia gravis. Saccharin was once upon a drug of choice. Remember this? Now it is not the drug of choice. It was earlier the drug of choice. But now rivastigmine and donacapil is mainly the drug of choice. Galantamine can also be used. There are preferred agents. Saccharin is no more used because it causes hepatotoxicity. Frequent dosing is required. Diarrhea is also occurring. Okay. This rivastigmine is also used in Parkinson's disease. It is also used in Parkinson's disease. Remember this. Rivastigmine has 2 Ds, AD, PD. Okay. Now organophosphorates. Simple. This is the normal structure of a acetylcholinesterase enzyme. It has got an anionic site and it has got a esteric site. Okay. Usually the acetylcholine binds to your esteric site and gets metabolized. When OPC poisoning happens, OPC is what? Malathion, parathion, DFP, difluorophosphate, diazenon, even naru gases. Okay. So when it happens, this OPC goes and binds competitively with the esteric site. So it competes. Remember this, it's a competitive inhibitor. But it's a competitive irreversible inhibitor. Usually competitive inhibitor means what? An enzyme will go and bind to the substrate usually. But when you give the drug, that will go and bind to the place where the substrate is also binding. But when you increase the amount of substrate, the enzyme, the inhibition can be reversed. So it's called surmountable inhibition. Whereas in case of OPC poisoning, the same competitive inhibition is irreversible. This is one classical example. Okay. So now, how do you treat this OPC? First is antidote is atropine has to be used as antidote because OPC causes all acetylcholine actions, meiosis, increase in secretions, bronchoconstriction, diarrhea, urination, hypotension, bradycardia, and finally coma. So for this to reverse, you have to use atropine, which is the antidote of choice for both OPC as well as carbamates. But there are some new drugs that are called as enzyme reactivators. You have to bring back this ACHC enzyme back to normal. Within 8 hours, if you use, within 6 to 8 hours, if you use, this is helpful. These are nothing but oximes. So when you give an oxime, this oxime will go and bind where? This oxime goes and binds to your anionic site, which is free. Now your OPC compound is in the esteric site. Now these oximes will form a bond with the OPC and it removes the phosphate. And it removes the phosphate that is present in the organophosphorus compound. But if after 8 hours it is given, that particular phosphorus undergoes aging. So it cannot be removed. So that's why it's irreversible. It becomes. But within 8 hours, if you give, you can still make some ACHC enzyme available for action. So this oxime goes and binds to the anionic site. Esteric site OPC is always present already. So it forms a bond with the phosphate and it removes the phosphate. That is the role of oxime. So it's called an enzyme reactivator. Paralidoxime, obidoxime, diacetyl monoxime or dobudoxime. Okay. So paralidoxime and obidoxime cannot cross blood-brain barrier. Whereas diacetyl monoxime, dobudoxime can cross BBB. So it can be used even if CNS symptoms are seen with OPC poisoning. It is contraindicated in carbamates. Why? This carbamates, OPC only goes and sits in your esteric site, whereas carbamate sits both in anionic site as well as your esteric site. Nothing is free. So oximes cannot act. Okay. Primary indication of oximes when there is respiratory depression, muscle weakness. Remember this, they'll ask this as an MCQ. When should an oxime be used? It should be used only when there are signs of respiratory depression and muscular weakness along with other OPC poisoning symptoms. There is one more compound that is called as triorthoseryl phosphate. It's called as triorthoseryl phosphate. It is actually a lubricating oil additive. It's an additive that is added to the lubricating oils. This can cause something called delayed neuropathy. It's also a form of OPC only. It can cause delayed neuropathy 1 to 2 weeks later after the exposure and causes demyelination of axons. This is called delayed neuropathy of OPC poisoning. It is because of why, it is because of inhibition of neuropathy target esterase. It doesn't inhibit acetylcholinesterase, but it inhibits something called as neuropathy target esterase, NTE. Remember this, they can ask this as an MCQ. Triorthoseryl phosphate inhibits NTE. That's why it causes delayed neuropathy. It can also cause something called as intermediate syndrome. That is because of cholinesterase inhibition. 1 to 4 days. After 1 to 4 days of exposure, you will get it. The one that comes intermediately after 1 to 4 days is because of cholinesterase, whereas delayed neuropathy is because of neuropathy target esterase inhibition. Uses of cholinergic, we'll just revise it. That's what we saw now. Muscarinic uses, it can be used in glaucoma. Pilocarpine, not now used because fluctuations in IP. Short-acting physostigmine and ecothiopate. This ecothiophate can be used. It's an OPC only, but it's the only therapeutically used OPC compound. Ecothiophate. It is not available in India, but is available in US as a topical ointment. Okay. It's the only OPC that is used therapeutically. Ecothiophate is the only OPC that is used therapeutically. Alzheimer's disease, we already saw. That is grand touring doctor. Belladonna poisoning, you use physostigmine. Reversal of muscle relaxants, nicotinic users. Neostigmine, pyridostigmine, myasthenia gravis. For diagnosis, you use heterofonium. For treatment, you use neostigmine, pyridostigmine. Cobra bite also, you can use neostigmine and pyridostigmine. Post-operative uses. For bethanocol can be used for paralytic ileus. Even neostigmine is mainly used. Urinary retention, bethanocol, B for B, bladder, neostigmine. So whenever bladder comes, remember bethanocol. Sjögren syndrome, cevimeline and pilocarpine for dry mouth. Now, this is the question of the day. Find out drug A, B, C, D in the figure given below. This is a very difficult question. Yesterday, I have not asked the question, so I put this question now, today. I explained it yesterday. What is given here is choline with combining with acetyl from acetyl-CoA forms ACH. The ACH goes and forms a synaptic vesicle. The synaptic vesicle goes and binds to the synaptic cleft and it is getting released into the postsynaptic cleft. The ACH is released by exocytosis. Then ACHC metabolizes acetylcholine to choline acetate and choline is again reuptake. So there are 4 drugs that we are given here that inhibits one of the steps. So let's take a look at the first A. What is it? What does it inhibit? It inhibits your ACH bundling into the ACH vesicle, synaptic vesicle formation. So what drug is this? Vesamicol. Remember this. Now B. Calcium influx is required for exocytosis of your synaptic vesicle to release the ACH. What drug stops it? Botulinum toxin. Botulinum toxin. Now, acetylcholinesterase is inhibited by, now only we saw it, physostigmine and neostigmine. This choline reuptake is inhibited by, same, it's in the name only, hemicolinium. Hemicolinium. So, A is vesamicol, B for B, botulinum toxin here, C drug is hemicolinium, and D is physostigmine. So, let's match it. So, A, B, C, D, vesamicol, botulinum toxin, choline, physostigmine, A, B, C, and D. So the option is this. They might ask, give a figure of the pathway and they insert drugs and they ask what is the inhibitor. These are all cholinergic drugs. Next class we will see that. But still yesterday I told you about this cholinergic drugs, so I am asking you a question here. Now, patient presents with severe weakness after working for 15 minutes every day for past 2 months. Whenever he works, he has weakness. He feels tired, fatigue. The muscles are fatigued. The physician performed tensilon test with 2 mg hydrophonium. The weakness worsened severely. In case of myasthenia gravis, the weakness will improve. Weakness will decrease. Whereas with cholinergic crisis, worsening of your weakness. Worsening of your weakness. So the answer here is cholinergic crisis. Okay. Lambert-Eaton system and myasthenia gravis, same types. No hypersensitivity. There is no hypersensitivity to tensilon noted clinically. Okay. So that's it for today's class. We have completed cholinomimetic drugs. Tomorrow we'll see cholinolytic drugs. Okay. So then cholinolytic drugs, then one day sympathomimetic, then sympatholytic. We have already seen about glaucoma. So ANS is completed. 5 days for ANS. That's all. Okay, 15 minutes. Okay. Thank you very much.
Sorry for the delay. And today it's a very small session again on, yesterday we had talked about placental abnormalities. So as a continuation, today we are going to talk about retroplacental clot. And as soon as I say the word retroplacental clot, all that comes to all of your mind is abruption. Okay. So today, so before we go into the class proper, I have a question from yesterday's class, which is very simple now. A placenta with accessory lobes is called, it's called succenturiate placenta. Okay. So placenta with accessory lobes is succenturiate placenta. You also know what is the definition for placenta previa. A placenta by ultrasound definition, which is covering the os, is placenta previa. You also know what is low-lying placenta. Okay. And you also have learned about vasa previa in yesterday's class. So today we'll go to the topic proper. Now this is a question for today. An ultrasound image is given, and you're all able to see the ultrasound image. I will outline it for you. Now this is the placenta. This is the placenta. Okay. The grading of placenta we are supposed to know. We will learn in a different class. And this is the fetal skull. Now we are able to see the fetus here. Okay. So we'll outline it like this. And this is the uterine wall, which I'll draw in a different color. Now this is the uterine wall. Okay. Now behind the placenta, you see what is marked here is the retroplacental clot. Okay. Behind the placenta here, it is marked as RP clot. I'll write here. So now this is the retroplacental clot. Okay. So this is a 22-year-old primey. Now the catchy words here, you have primey, 32-year-old, 34 weeks of gestation. So she's in the 3rd trimester. She complains of painful bleeding per vagina. So this word painful bleeding is very important. Uterus is 36 weeks. Now this point has to be noted. 34 weeks gestation, but 36 week size uterus. So that means the fundal height, I'll write in short, fundal height. The fundal height is more than the period of amenorrhea. Okay. Again, we have keywords. Uterus is tense and tender. Fetal heart rate is normal. What is the most important diagnostic point that you get from ultrasound? So this ultrasound, they're asking you to interpret the ultrasound. So nowadays you have lots of questions based on interpretation of ultrasound. They're asking you whether this is placenta previa, whether this is adherent placenta. We had studied all the types of adherent placenta in yesterday's class: accreta, increta, and percreta. Accreta is adherent, increta is invades the myometrium, and percreta is even it perforates the myometrium. Is it a retroplacental clot? Is it placental calcifications? Now here everything in the history points out towards abruption. I'll be talking about it in detail in today's class. In tomorrow's class, we'll be talking about this abruption only. So here what you see is retroplacental clot. Okay, we'll come to this question again after we talk about abruption. And another question, what is the risk factor for abruption? And we have a question based on the definition of antepartum hemorrhage. So this is a question based on the definition of antepartum hemorrhage. The previous question is a question which is based on the risk factors for abruption. So you should be knowing the risk factors for abruption. Is it common in primary or multi, or is it common in younger age group or advanced age group? What are the other specific risk factors? You should be knowing all these. So before we go into all this, now antepartum hemorrhage, we will talk about the definition of antepartum hemorrhage, and we will talk about the causes of antepartum hemorrhage. So as the naming goes, anti, what is anti? Before, partum, delivery. So a hemorrhage before delivery. So that is very simple, before delivery of the baby. So now this is bleeding before delivery of the baby. Antepartum, from what time onwards? So from the period of viability. So we take in India the period of viability still as only 28 weeks. We know 28 weeks approximately baby is 1000 grams. So we still take 28 weeks, though here the Royal College definitions of abruption, the ACOG definitions of abruption may vary. Okay, so bleeding from the female genital tract. I'll write the complete definition for you. So what is antepartum hemorrhage? It is bleeding from the female genital tract. It is not specifically given, it is uterine bleeding. Okay, so bleeding from the female genital tract after the period of viability, before the delivery of the baby. Okay. So anywhere in between this interval, if there is bleeding from the female genital tract, okay, so we will draw it. So this is placenta. Okay, we'll draw baby. So it is bleeding from the female genital tract anytime after the period of viability and before the delivery of the baby. This is antepartum hemorrhage. So what are the causes of antepartum hemorrhage? So when we take the causes of antepartum hemorrhage, the most important cause or the predominant cause is placental. Okay, bleeding from the placenta. Okay, so that is 3 important causes that we have to study. One is abruption. Number 2 is you have placenta previa. And yesterday you can say okay, placental cause, it's because of a fault in the defective attachment of the umbilical cord to the placenta, which is vasa previa, and we have dealt. So 2 important causes. So abruption and placenta previa, you know, it is maternal bleeding, and vasa previa, you know, it is fetal bleeding. So in the causes, it is placental causes. Okay. The other causes also have to be ruled out. Okay. Local causes in the female genital tract. Say for example, if there is an erosion in the cervix, a simple cervical erosion, or a cervical polyp, or even frank cervical carcinoma, or even cervical intraepithelial neoplasia, which is significant. Okay, it's an ulcer, or any other polyps, any other lesions in the vagina. which can bleed. So local causes also have to be taken into account. As I already told you, the definition itself strictly says it's bleeding from the female genital tract. Okay, so these two are most important causes. Sometimes it's not local cause, it's not placental cause. In so many causes, sometimes practically also we see it is unclassified. Does not fall into any category. The mother has a bout of bleeding and then all of a sudden it settles down. So sometimes we see unclassified cases also. So three important causes: local causes, placental, and unclassified. The most important ones, abruption, placenta previa, we are supposed to study in detail. Okay, so what is abruption? Abruption means, each and every word here is important. It is premature separation of placenta, not separation of placenta. The most important term to be noted here is premature separation of normally situated placenta. Normally situated placenta. Now I'll tell you what this means. What this normally situated placenta means. Okay. So where is placenta normally situated? Placenta is normally situated in the upper uterine segment or the lower uterine segment. It is normally situated in the upper uterine segment. Okay. We all know by definitions what is upper uterine segment, what is lower uterine segment. We know isthmus only forms the lower uterine segment. So placenta here normally situated in the upper uterine segment. Now, if this placenta prematurely separates, okay, now if this placenta prematurely separates, then it is abruption. Is that okay? Fine. Now, why is a placenta prematurely separating? And what is the etiology for abruption? What is the etiology for abruption? So that is a very important question. Advanced maternal age. So now these two I have grouped because many a times in exams and questions, you will get questions like this. All of the following are risk factors except. All of the following are risk factors for all the conditions in obstetrics and gynecology. Okay. All of the following are risk factors for say for example abruption, or they'll give you placenta previa, or they'll give you cord prolapse or postpartum hemorrhage. Anything can come. So you should know the risk factors. It's very difficult just to memorize the risk factors and then just recall. You should know why it is. So here you remember advanced maternal age and multiparity. So for both placenta previa and abruption, this is common. So for both placenta previa, I'll write as PP, placenta previa and abruption, the common risk factors are advanced maternal age and multiparity. Okay, so two most other important risk factors. So abruption itself can be grouped as whether it is abruption because of preeclampsia or abruption because of other causes. So preeclampsia is a very important cause of abruption. Okay, so we put a into mark. In every case of abruption, you need to ask this history. This is very important, whether there was any trauma to the abdomen. It can be a road traffic accident. It can be a fall. It can even be history, a child, maybe 5-year-old, 6, 7-year-old kick on the abdomen, or sometimes even domestic abuse. Okay, so all this history has to be taken into account when a woman when you have a woman presenting with bleeding and when you diagnose abruption. So please take into account the history of a blunt abdominal trauma which has led to the separation of placenta. So abruption, two important risk factors are, one is preeclampsia and the other is abdominal wall trauma. Other uterine causes of abruption has to be taken into account, like whenever there is over distension of uterus. Okay, so whenever there is over distension of uterus, when will uterus be over distended? Multiple pregnancy, polyhydramnias. Okay, so in these cases, you always have to remember this effect called rubber stamp effect, which I always tell. So now, for example, take now this is a sheet of rubber. Okay, now if you have a small stamp attached here. This is a rubber and this is a stamp. Now, when you compress the rubber, what happens? The stamp will get detached. So it's like it's an easy concept. You have a sheet of rubber to which you are attaching a small piece of paper. When you compress the rubber, that piece of paper will get detached. It is the same concept. Now, this thing you compare and you take it, compare it to uterus. Now, this thing you compare it to uterus and the small stamp that has been attached, you compare it to placenta. So what happens naturally? The placenta will get detached. So whenever we have over distended uterus, say multiple pregnancy or polyhydramnias, and when there is a decompression, and when there is a shrinking of uterus, as may happen with a rupture of membranes, or sometimes when you do a procedure like artificial rupture of membranes, or when there is PROM, now this over distended uterus starts decreasing in size, and the placenta that is attached will get detached from the uterine wall. Okay, so other procedures also have to be taken into account. The external cephalic version also has to be taken into account. So now we have very little time with this. So I'll go back and discuss again the 4 most important points that you need to remember with respect to risk factors of abruption are: number 1, advanced maternal age, don't forget it. Number 2, multiparity. Please remember, in multiparity it's common. You might be of the doubt that preeclampsia is common in nulliparous. So abruption also is common in nulliparous. No, not like that. So take that into account. Preeclampsia is common in nulliparous, in preemies. Preeclampsia is common in preemie, but abruption and placenta previa both are common in multi. Okay, so please take that into account. And number 3, abdominal wall trauma has to be taken into account, and any other procedures, multiparity, polyhydramnias also have to be taken into account. And also think of the other procedures causing this problem. Okay. Now, the consequences of abruption. So what are the consequences of abruption? So consequences of abruption, we need to study as a sequence. So say this is uterine wall. So now this is the low uterine segment. We are going to talk about placenta, which is like normally attached to the upper uterine segment. Okay, we'll draw the umbilical cord. We'll also draw the fetus. Okay, we'll also draw the amniotic membrane. Now this is a rough picture of what will happen when the placenta prematurely separates. Now imagine if this placenta prematurely separates, we will have a collection of blood behind. Now this is the topic for today, and this is what we are going to discuss: a retroplacental clot. Is that okay? Fine. Now this retroplacental clot is basically concealed abruption. Concealed abruption. Now blood can also trickle, and this can present as antepartum hemorrhage, which is revealed antepartum hemorrhage. So this abruption bleeding can be concealed, it can be revealed. Most common type. Sometimes this question comes in the exam. What is the most common type of abruption? Now it is mixed. This point carries very big significance when it comes to clinical management of the patient. You can never assess a patient when she will go into hemodynamic collapse just by looking the amount of revealed hemorrhage, because some amount of concealed hemorrhage accompanying the revealed hemorrhage is the rule, because we know mixed type is very, very common. Is that okay? Now, because of this, separation, now mother will definitely become anemic. She can go into shock. So the maternal complications, shock. Okay. Number 2, from the retroplacental clot, thromboplastin can get released into the systemic circulation, stimulate disseminated intravascular coagulation series leading to DIC. Okay, now this shock can also compromise on the renal perfusion, and it can lead to renal compromise, or it can lead to an acute pre-renal type of renal failure. Because of any of the 3, maternal death is common. Obviously, for the fetus, what can happen is fetus is deprived of its blood supply, so distress is common, or in fact, it can even lead to intrauterine death. So these are the 2 important causes. Other important consequence of abruption is that now blood can get seep into the layers of myometrium here, and it can compromise the contractility of the uterus. Now seepage of blood into the myometrium of the uterus, now it is called tubular uterus, and this can fail to contract properly. Now, the tubular uterus can fail to contract properly and can lead to postpartum hemorrhage. So, I wanted to highlight basically these 3 important points with reference to maternal complications, shock, DIC, and renal failure. Okay, and fetal distress and IUD, main fetal complications. Okay, and we also know the most common type of abruption is mixed. So we go back to the question here. So we have talked about definition of antepartum hemorrhage. We've talked about definition of abruption. We've talked about risk factors of abruption. And also we have seen the most important maternal and fetal consequences of abruption. Is that okay? Now the questions for today. This question already explained. So now you know this clinical case scenario is a case of abruption, and what you're seeing in the ultrasound picture is a retroplacental clot. Okay, which of the following is not a risk factor for premature separation of placenta? Advanced maternal age is definitely a risk factor. Primary, no. Abdominal wall trauma. Smoking and cocaine abuse are also very important risk factors for abruption. So this is the odd man out. So here answer is primary. APH is bleeding from the female genital tract after the period of viability and before what? Delivery of the baby. Okay, before delivery of the baby. That is antepartum hemorrhage. Okay. So that is all for today. And tomorrow we will be talking about other important clinical features of abruption, all the clinical features of abruption. And we'll also be talking about the management of abruption. I'll come up with a clinical case scenario, 2 clinical case scenarios, and the management of abruption. So thank you all for your patience listening today. I'll meet you tomorrow.
Hello, am I audible? Am I audible? Can I just get a confirmation if I'm audible, please? Okay. Hello everyone, I'm Dr. Sneha. Today we'll be covering a very important topic on gestational diabetes mellitus. Let's start with an MCQ. Which of the following is not a risk factor for developing GDM? Your options are Indian ethnicity, maternal age of less than 25, previous baby of 4.6 kg, and if maternal BMI of 32. Now let's look at, so there are different risk factors for developing GDM. Pregnancy is quite, it's a weird state where suddenly a patient can develop diabetes or suddenly they can develop hypertension, and all of this can resolve after the baby is born. This is all because of the hormonal changes that is constantly occurring inside the mother's body. But not all of them develop GDM. There are certain risk factors, okay? Now the answer for this is answer B, maternal age of less than 25. Actually, age of more than 25 is one of the risk factors. So let's quickly list out the risk factors for GDM. We'll start with the mother and then look at the previous obstetric history. In the mother, as we already saw, when the age is more than 25, Indian ethnicity, being Indian itself is a risk factor for developing GDM. And that's why we subject every pregnant woman in India to have a screening. We don't do selective screening, we do universal screening. Okay. If the mother's BMI is more than 30, if there is any first degree family history of diabetes mellitus, such as mother, father, or siblings who are positive for diabetes mellitus. Now, these are some of the maternal risk factors for having GDM. Also, if she has any medical conditions, especially if the mother has hypertension, previous history of PCOS, or metabolic syndrome, or obesity, these can increase her chances of having GDM during pregnancy. What about previous obstetric history? If she's been pregnant previously, and suppose if she's had history of GDM in the previous pregnancy, as with any other obstetric condition, the recurrence is higher in this case. Okay. If the previous baby's weight was more than 4 kgs or 4.5 kgs, in other words, if the baby was big, there is a chance that she might have GDM in this pregnancy. Or if the baby had adverse complications such as stillbirth, which was due to GDM complication, then again she has a very high risk of developing GDM in this pregnancy. Okay, so now these are some of the risk factors in GDM. So if you get a clinical scenario, look out for all these risk factors. Let's look at the next MCQ. Which of the following hormone is not the hormone responsible for development of GDM? So there are certain hormones that can cause development of GDM in a pregnant woman, but which of it is not responsible for it? Your options are human placental lactogen, cortisol, estrogen and progesterone, and thyroxine. The answer here is thyroxine. Thyroxine actually does not have any major role in sugar control in pregnant women. It has different functions in maintaining the metabolism in the woman's body, not actually in maintenance of sugar levels. Whereas all these three options are responsible for development of GDM in a woman. Okay, so now let's quickly look at pathogenesis of how GDM occurs. Why do some women develop increased sugar during pregnancy and some women do not? Basically, every woman, whether they have a risk factor or not, they develop a diabetogenic state during pregnancy. That means that every woman's body has increased sugar levels or glucose level during pregnancy. Why does this happen? Because it is the responsibility of the mother to make sure that the baby gets glucose continuously so that it can have proper growth and proper nutrition in the womb. But irrespective of whether the mother is fed or not, that What I mean to say is that even if the mother is starving, the baby will act like a parasite and keep sucking out glucose from the mother's body. So this is the main function. Remember this point. The baby has to be continuously supplied with glucose to make sure that it is growing properly. Let's look at two conditions. In the first condition, the mother is in fasting state. For example, in the morning, she's just waking up and she's not had any food. Even then, the baby will take glucose from the mother even in the fasting state. So what happens is that the glucose level in the mother's body comes down because all the glucose has been supplying to the baby. What happens is that it leads to fasting hypoglycemia. Okay. Next, if the mother is in fed state, now she's had her breakfast and you can see that the glucose level in the mother's body is high because she's just had breakfast. Okay, so this is more convenient to the baby now has more glucose supply from the mother because the mother's stored supply of glucose is increased now. But to make sure that all these glucose is not very fastly supplied to the fetus, it should be given in a stable condition for a very long time. Okay, to make sure that the mother's body develops insulin resistance. When the glucose level increases in the body, insulin is secreted to reduce the level of glucose in the mother's body. But if the glucose level reduces, then the supply to the fetus will also start reducing. To prevent that, what happens in pregnant women's body is that it starts developing insulin resistance. And some of the hormones that is responsible for developing this insulin resistance is human placental lactogen. This is the most important hormone that's produced from the placenta. The others include cortisol and estrogen and progesterone. So these are hormones that are responsible for producing insulin resistance. Make sure that the glucose level is high, very high, even in the postprandial state, so that this glucose is supplied to the baby constantly. Okay, so what I imply to state that after the fed state, postprandial, after she has the meal, the mother will still continue to have high glucose levels. Excuse me. Just to make sure that this glucose is always available to be supplied to the baby. Okay, so now all these three factors that I have included inside the red box is the main pathogenesis of how a woman develops GDM. In some women, all these three mechanisms is exaggerated, especially in women with risk factor, and this is why it leads to GDM in certain women. But as a rule, all pregnant women are in diabetogenic state. All these hormonal changes are maximum at around 24 to 28 weeks. This is the peak at which all these hormones, these diabetogenic hormones, are at maximum action. So the best time to detect GDM will be at 24 to 28 weeks. And this is the reason why this is the gestational age at which all the screening test is normally done. Okay, let's look at the next question. By DIPSI guidelines, above which level of glucose following 2 hours of 75 gram GTT is considered as GDM? That is, in DIPSI, what is the level above which you diagnose GDM? Okay, your options are 153, 130, 140, and 120. This is purely a memory-based question and it's a numerical value-based question. And let me go ahead with the answer. The answer here is 140. Okay, now this is also one of the questions, similar question was asked in the recent INICET, the cutoff for GDM by another guideline. So I thought, let's look at the guidelines quickly and let's look at their cutoffs in a single chart. Okay, so mainly there are 3 different screening guidelines. One is an international guideline called as IST-PSG. Second is an ACOG based guideline. And third is the DIPSI guideline. DIPSI is the Indian guideline. Okay. Now let's look at it one by one. When is each of this offered? IAD PSG is first. There are 2 different times in which it can be offered. First is when the patient comes for her first visit or booking visit in her first trimester. Okay, you can do a test then. If at that time she tests negative for GDM, you can repeat the test at 24 to 28 weeks. Suppose if she tests positive for GDM or the values are high at this time itself, you can diagnose her to have GDM at the booking visit itself. Okay. In ACOG, you do the test at around 24 to 28 weeks because as we saw from the pathogenesis, this is the period at which all the hormones are at maximum action. Dipsy says that any time the woman comes for her first visit, because in India, women might not come for proper booking in the first trimester. They can come for late booking. They can even come right at delivery. So it does not mention exactly at what gestational age. Any time, whichever is her first visit, irrespective of her gestational age, you can do the testing. Next, is fasting required for any of these tests? For the first test, yes, fasting is required. For ACOG, ACOG is done as a two-step method. Okay. For the first step, fasting is not required. But for the second step, fasting is required. For DIPSY test, fasting is not required. This is also one of the advantage in DIPSY because, for example, an Indian woman is coming to a PHC for her first visit and she's had her breakfast. You ask her to come back again the next visit in fasting. You don't know if she'll come back or not. So in this test, fasting is not required, makes it more convenient. Okay. Next, how is it done? This is the most important part. So in IAD PhD, we saw that the test can be done during booking as well as 24 to 28 weeks. So let's look at booking first. So you give 75 grams of glucose to a woman in fasting state and you measure the, in booking, you just measure the fasting glucose. Okay, no need to give 75 grams. And if it is more than 92 at this stage, you diagnose her to have GDM. Suppose if it is less than 95, okay, 92, sorry, then you repeat the test at 24 to 28 weeks. And here you give a 75 gram GTT test. You give the 75 gram glucose in fasting state and you take three values. One is fasting and then 1 hour after she's had the 75 grams, 2 hours after she's had the glucose. If the fasting is more than 92 or the 1 hour value is more than 180 or the 2 hour value is more than 153. Okay, if any one of this is positive, then you diagnose her to have GDM. Okay, so this is how it is done. What about ACOG? ACOG is a two-step method. Okay, so the first step is called as a glucose challenge test, where you don't require fasting. You just give her 50 grams of glucose and you measure the value after 1 hour, the glucose value, and if it is more than 130 or 140, depending on the hospital protocol, you can take either 130 or 140. Then you subject the patient to 75 gram GTT, and for this you require fasting. Okay, only if this is positive. If it is less than 130 or 140, you do not need to do anything else. So that is why this is called a two-step approach. Okay. And after giving the 75 grams GTT, here you take four values. One is fasting, 1 hour after 75 grams, 2 hours after, and 3 hours after. The values are 95, 180, 155, and 140. Okay. And to diagnose GDM by this method, 2 of them has to be positive. 2 values has to be more than the cutoff that is given here. Whereas in IIT PhD, any one is enough. Okay. Any of the 2 values is more than the cutoff given here, then you diagnose them to have GDM. Okay. Let's look at DIPSI. DIPSI is very simple. It is just one step. You give the patient 75 grams of glucose, irrespective of her fasting days. Measure her glucose 2 hours later, sugar values 2 hours later, and if it is more than 140, you diagnose her to have GDM. Okay. Some of the numbers might be confusing, but since a question has been asked, it might be better to memorize some of these values and how each of these tests is done and when it is done. Okay. Cutoff we have already discussed. So the last MCQ for today, which of the following complication risk is not increased in GDM? Your options are gestation hypertension, polyhydramnios, macrosomia, and congenital anomaly. Your answer here is congenital anomaly. Okay. The rate of risk of congenital anomaly is increased in women who's already diagnosed to have diabetes, frank diabetes, or what we call as overt diabetes mellitus. The patient already has a comorbidity of diabetes even before she's diagnosed to have pregnancy. Okay, because in diabetes mellitus, especially if it is uncontrolled diabetes mellitus, increased glucose level can cause release of lot of free radicals in the mother's bodies, and in this free radical is what is responsible for developing different kind of anomalies. Okay, whereas GDM is a condition where the woman develops high sugars for the first time in pregnancy, and it is very unlikely that even at the time of diagnosis, she will have very high glucose, which will lead to development of free radicals. So usually in GDM, it does not cause congenital anomaly. It is not one of the risk factors that is seen. So this brings us to the last slide. Let's quickly summarize the complication that can arise because of GDM in the mother as well as the baby. Okay. In the mother, because of GDM, she can develop gestational hypertension along with GDM. Okay. They have a higher risk. She can develop infections if the sugar level is not controlled. She can develop polyhydramnios because when the sugar levels are increased in the mother, it causes increased sugar level in the baby as well, which leads to increased insulin secretion, and it leads to polyuria in the baby, and it's the urine that causes the amniotic fluid. So because of polyuria in the baby, there will be polyhydramnios for the mother. Okay, she can have preterm labor because of big baby and polyhydramnios. She can have labor dystorcias. That is any labor delay or arrest in the labor progression. Because of big baby, there can be shoulder dystocia. Because of that, there can be perineal tears. There can be PPH. Now, these are some of the complications that can occur in the mother. What about fetus? There can be miscarriages, especially if the sugar levels are slightly at higher level during diagnosis. There can be development of macrosomia if the sugars are not controlled, because of the same principle. When the sugar levels in the mother is high, it will cause higher sugar level in the baby, which leads to increased insulin in the baby's body. Insulin is an anabolic hormone, so it will lead to more fat deposition in the baby's body, causing macrosomia. Okay. And this macrosomia is the reason why all these complications can occur: preterm, labor dystocia, shoulder dystocia, perineal tears, and PPH can be because of polyhydramnios as well as macrosomia. Okay, macrosomia is the main complication in the fetus. Infant, after the baby is delivered, the baby is called infant of diabetic mother, and this will be dealt in a different topic because these babies can have different complications as well. Okay, so that brings to the end of today's session. I hope that was a useful session, and tomorrow we'll see again with another important topic. Thank you so much.
Good evening, everyone. So today we are back with the discussion on the acute disorders related to severe hyperglycemia. So before starting the day, let's do some MCQs. These MCQs are based on the topic which we learned yesterday, right? So the precursor for ketone body formation is option A, acetyl-CoA, option B, malonyl-CoA, option C, propanyl-CoA, option D, all of the above. So yesterday we learned that ketone body synthesis basically occurs because of increased fatty acid oxidation and increased production of acetyl-CoA. So the starting is, the precursor is acetyl-CoA, right? So let's start. Let's do one more question. The regulatory enzyme for ketogenesis is option A, thiolase, option B, HMG-CoA synthase, option C, HMG-CoA lyase, option D, beta hydroxybutyrate dehydrogenase. So the correct answer here is HMG-CoA synthase. Yesterday we learned that the key regulatory enzyme for ketogenesis is HMG-CoA synthase. Let's do one more question and then we'll enter to today's topic. The ketone body that is not metabolized is option A, acetoacetate, option B, beta hydroxybutyrate, option C, acetone. Yesterday we saw that during the ketogenesis process, we make acetoacetate, and then this acetoacetate is acted upon by the enzyme beta hydroxybutyrate dehydrogenase and is converted to beta hydroxybutyrate, which circulates through the blood and goes to the non-hepatic tissue, which can utilize ketone bodies, right? And some amount of acetoacetate can also be metabolized. But which is the one which cannot be metabolized? It is acetone. Acetone cannot be metabolized in the body. So it is not metabolized. So now we yesterday saw that when we are talking about diabetes, it leads to a state of hyperglycemia, right? This hyperglycemia can lead us into two types of complications. One is the acute disorders and the other is the chronic disorders, right? In the acute disorders, yesterday we learned about ketosis, right? Diabetic ketoacidosis. That was yesterday's topic. Today we will look about the other acute disorders of hyperglycemia. Okay, so let's read a particular case scenario. An elderly individual with type 2 diabetes mellitus with a several week history of polyuria, weight loss, and diminished oral intake presented to the emergency department in a highly lethargic state. The physical examination reflects profound dehydration, okay, and hyperosmolality and reveals hypotension, tachycardia, and altered mental status. Urine was positive for Benedict's test and negative for Rothera's test. Right now, the important thing here is the initial part of it. The question looks very much like a scenario of diabetic ketoacidosis. However, the important thing here is that Rothera's test was negative, with Benedict's test being positive, indicating that a reducing sugar was present in the urine and the person is having type 2 diabetes mellitus with the history of polyuria. However, there is no ketone bodies in the urine, right? So this situation is what we call as the hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state, often short formed as HHS, right? Now, this is less common than DKA, right? DKA, diabetic ketoacidosis, is way more commoner than HSS, and it is seen in the type 2 diabetes mellitus, usually in the older individuals with a age group more than 65 years, approximately. However, the mortality is way higher than mortality in HHS is higher than ketoacidosis. Diabetic ketoacidosis is way higher in HHS. Okay, now often it presents with an altered level of consciousness. That is, the cerebral symptoms, the CNS symptoms are present here. We will discuss why it happens like that. Now, there are certain precipitating factors for the development of HHS, like a myocardial infarction or a cerebrovascular stroke, sepsis, pneumonia, or some serious infection, any debilitating condition, and most importantly, decreased water intake. Decreased water intake. Now, let's look at the pathophysiology of HHS. Now, HHS is often also called as hyperosmolar. The other name for HHS is hyperosmolar non-ketotic coma, short formed as HONK. Now, every HHS might not go into a state of coma. However, HHS, if not treated, can go into a state of coma. Let's look into the pathophysiology. What are the things that are happening? So, like yesterday we discussed, in the normal state, you have the pancreas, which secretes insulin, which affects the liver and enhances glycolysis, glycogenesis, right? And also affects the skeletal muscles and adipose tissue, right? But in a case where we have relatively less amount of insulin, right? What happens? The counter-regulatory hormones increases. Which are the counter-regulatory hormones? Glucagon, catecholamines, growth hormone, and so on. Out of this, glucagon affects the hepatic tissue, causing an increase in two things. One is glycogenolysis and gluconeogenesis. Both these things increase the circulating glucose levels, right? Increases the circulating glucose levels. And along with this, there is decreased utilization of the already present glucose in the circulation. Why? Because you have the GLUT4 receptors, which act only if the insulin is present. So they are not affecting. So thus there is a hyperglycemic state, right? So there is a hyperglycemic state. Along with this, right? Along with this, if there is an inadequate fluid intake, what happens is, what you're going to do is, we have an increased glucose, right? Obviously, in the initial stage, what will it lead to? It will lead to polyuria. We learned that the renal threshold for glucose is 180 milligram per deciliter, right? Because once it crosses 180 milligram per deciliter, the body has a system to excrete it through urine and thus bring back the glucose to the normal levels. Yes, correct. So now, because the glucose is very highly getting increased, there will be polyuria. Now, glucose is osmotically active. Glucose being osmotically active, along with it, it pulls in water, right? It pulls in water. This causes hypovolemia, and also increases the osmolality. Initially, this is fine. Okay, we are having polyuria, osmolality is going on. But as it goes on increasing, as the amount of glucose in the blood goes on increasing and the polyuria goes on increasing, at one stage, the GFR starts decreasing. The GFR starts decreasing, and initially there will be azotemia, and finally the kidneys will be having a problem in filtering out the glucose. This leads to the state for hyperosmolar hyperglycemic state, right? So this impairs the glucose utilization in the skeletal muscles, There is osmotic diuresis, and this osmotic diuresis causes intravascular volume depletion. Okay, now how does it lead to coma? What is the coma? Basic thing is, you in the ECF, in the extracellular fluid, you have increased levels of glucose, right? So this is becoming hypertonic, which causes the extravasation of fluid from the cell to the outside. Thus, this, when it happens to the cerebral cells, causes the altered mental status, and if not corrected on time, leads to coma. So what are the lab abnormalities that you see? According to Harrison's, I will quote here Harrison's. Okay, what Harrison says is the hyperglycemia in such cases will be as high as 1000 milligrams per deciliter. As high as 1000 milligram per deciliter. But certain article says that if the hyperglycemia is more than 600 without ketone bodies, you should consider the case scenario of HHS. There is hyperosmolality. Again, Harrison says that it will be more than 350 milliosmoles per liter, and there will be pre-renal azotemia. Okay, now normally the question here is, if you looked at the pathophysiology, it looks very similar to that of the pathophysiology of diabetic ketoacidosis. But what you have to remember is, if we consider diabetic ketoacidosis with HHS, the insulin to glucagon ratio is very low here as compared to the insulin glucagon ratio in this patient. This can cause ketogenesis or ketosis, whereas this insulin glucagon ratio, it is low, but it is not able to cause ketosis. So the classical scenario here is, you will have a hyperglycemia, hyperosmolality, and pre-renal azotemia without ketone bodies. However, there can be a slight anion gap metabolic acidosis due to lactic acidosis. If at all in these patients we see ketone bodies, it will be moderate ketonemia due to starvation. That is, a person who is having a hyperosmolar hyperglycemic state, who is in a hyperosmolar hyperglycemic state, if that person goes into starvation, then there is a chance of development of diabetic ketoacidosis, right? So coming back to our question, this is a case of hyperosmolar hyperglycemic state. Okay, the important point here was that the patient had a history of polyuria, there was diminished oral intake, right? That is, the fluid intake was less, profound dehydration, hyperosmolarity, okay, and along with hypotension, tachycardia, and altered mental status. Urine was positive for Benedict's and negative for Rotheras. Okay, all of them show towards the hyperosmolar hyperglycemic state. Apart from this, the typical symptoms of typical symptoms of diabetic ketoacidosis, such as nausea and vomiting and abdominal pain, is usually absent in these patients. Okay, now since we are discussing about the acute complications of hyperglycemic state, one of the complications is lactic acidosis. This happens because of the overproduction or underutilization of lactic acid. What leads to the overproduction? The increased anaerobic glycolysis. And the underutilization is because of a decreased functioning TCA and the oxidative phosphorylation. Now, this is a rare complication. This rare complication used to happen when patients were treated with biguanides, which were an oral hypoglycemic agent. And this biguanides used to affect the TCA and decrease the oxidative phosphorylation, leading to lactic acidosis. However, in the recent years, due to the better oral hyperglycemic agents such as metformin, lactic acidosis is a rare complication, right? One of the other complications of this disorder is hypoglycemia when you put the patient on treatment. Okay, when you overcorrect the hyperglycemia, leading into a hypoglycemia, it leads to the complication of hypoglycemia to an extent prevented by the CGM, which we studied 2 days back, that is continuous glucose monitoring. It can, to a long extent, prevent the patient to going into a state of hypoglycemia. So let's try answering one more question. Which of the following metabolic pathways are activated by insulin? Lipolysis, ketogenesis, gluconeogenesis, or glycolysis? Lipolysis, ketogenesis, gluconeogenesis, or glycolysis? Yes, you're absolutely correct. The correct answer here is glycolysis. Okay, in the absence of insulin, we have lipolysis, ketogenesis, and gluconeogenesis taking place. So the metabolic alterations that happens in diabetes is number one, hyperglycemia. Okay, now along with it, we have lipolysis. This is because of the absence of insulin attached with the increased amount of catecholamines and growth hormones. We have increased ketosis, ketone bodies, right? And then we have the increased influx of fatty acid in liver, leading to a situation called as fatty liver. It is very amino acids, right? So all these are the metabolic alterations that happen in diabetes: hyperglycemia, lipolysis. So there is increased fatty acids and thus triacylglycerols in the circulation, ketosis, increased influx of fatty acids into the liver, causing fatty liver, and proteolysis, so that glucogenic amino acids are there. Okay, so that's my time for today. Tomorrow, we will meet again with a small topic and have a healthy discussion. Thank you.
I welcome all of you for the high yield series in surgery for upcoming NEET PG and NEET PG or next PG. Which of the following is the best anatomical position of the patient to prevent air embolism in a patient with a penetrating chest trauma? So it is very clear in a penetrating chest trauma, to prevent air embolism, which position you will take? Lateral recumbent, Fowler, prone, Trendelenburg position. The answer is Trendelenburg position. Trendelenburg position, what is Trendelenburg position according to Schwartz? Yes, at down position. And bronchovenous air embolism is frequently overlooked lethal complication of pulmonary injury. Air embolism can occur after a blunt or penetrating trauma when air from the injured bronchus enters an adjacent injured pulmonary vein and returns air to the left heart. Air accumulation in the left ventricle impedes diagnostic diastolic filling, and during systole, air is pumped into the coronary arteries, disrupting the coronary perfusion. The typical case is a patient when a penetrating thoracic injury who is hemodynamically stable but experiences sudden cardiac arrest after being intubated, placed on positive pressure ventilation. Patient should be placed immediately in the Trendelenburg position to trap the air in the apex of left ventricle. So if there is the apex of the left ventricle, the air will not go to the aorta. Emergency thoracotomy is followed by cross clamping of pulmonary hilum on the side of injury to prevent further introduction of air. Very clear. So put the patient in Trendelenburg position. So very, very pertinent question. It can be asked in exams. So in case of penetrating trauma, chest trauma, to prevent air embolism, put the patient in Trendelenburg position. Very clear. So to find more interesting questions like this, yes, join Speed Learning app and also log on to daily classes on Speed Live. And there are beautiful, fantastic lectures taken by wonderful 19 faculties. Keep going. I welcome the Speed Learning app, all of you. Thank you.